Good morning. I would like to introduce my PhD topic, which is about conservative therapeutic possibilities for extra and intra-articular temporomandibular disorders. My name is Kata Kelemen, and I'm working at the Department of Prosthodontics, Semmelweis University. My vision is to establish a TMD protocol that is available for all the patients apart from the localization of the dental offices, and also to make an emphasis on prevention and therapy as well, and to have a proper funding to increase the level of evidence. Here you can see my specific goals. Right now I'm working on 2 systematic reviews and meta-analyses. We would like to investigate the conservative therapeutic possibilities for myogenic temporomandibular disorders and also for arthrogenic temporomandibular disorders as well. My first project is about investigating the efficacy of additional occlusal splint therapy to physiotherapy in adults with myogenic temporomandibular disorders. I have already sent my manuscript to language editing, and hopefully this week we can submit our work in the Journal of Dental Research. As a little bit of the background, temporomandibular disorder is the 3rd most common stomatological disorder, and the 10th or the 15% of the population has this kind of disorder. The most common type is the muscle disorder group, and its therapy we can use either occlusal splint therapy or physiotherapy as well. The unmet need is to find a pain-relieving method, so our aim was to investigate which reversible and conservative therapy offers the best results in decreasing the symptomology. Our clinical question is there a difference in efficacy of additional occlusal splint therapy to physiotherapy in adults who have myogenic temporomandibular disorders? In the patients, we included adults with local myalgia and myofascial pain. The intervention was additional splint therapy to physiotherapy, manual exercise, education, and counseling. And as a comparator, we use physiotherapy, manual exercise, education, and counseling as well. As the primary outcome, we measured the range of motion, and the secondary was improvement in quality of life. Our hypothesis was that the additional occlusal splint therapy is more efficient. I have done the systematic search in 4 major databases, and after the selection process, we have found 7 articles that we use for both qualitative and quantitative synthesis as well. According to Jeffrey Oxon, the TMD symptomology has 3 main symptoms. The first one is the movement restrictions. As this is objective, it would be the primary outcome, and we can measure it with a ruler or a caliper in millimeter. The second one was the pain perception that was measured on a visual analog scale. As this is subjective, we consider that as a secondary outcome. And the third would be the sound effects, but unfortunately we could not find any articles, but additionally we added another secondary outcome, which was the quality of life. Here you can see my first forest plot, which is about the pain perception at the 1 month follow-up. 4 articles were included, and the population is quite homogeneous. The effect was mean difference, which is 0.03. And this result is both mathematically and clinically not significant. Our second outcome was the maximum mouth opening at the 1 month follow-up. 2 articles were included, and here the effect was mean difference, which was 1.11. And here some adverse events can be observed, but for further conclusion, some other RCTs are needed to implement. We have also made an analysis on comparing pain perception at the baseline and at the 4 weeks follow-ups as well. In both of the analyses, 5 articles were included. The population heterogeneity is quite big. It's because of the last article, because there the patients could take some painkillers as well, and this can unfortunately modify our results. And both the results are mathematically and clinically significant as well, but there was a little difference between the 2 numbers, so it can questioning the usage of the additional splint therapy. We have also compared the maximum mouth opening at the baseline and at the 1 month follow-up as well. Only 2 articles were included, and the heterogeneity is quite big, because in the last article, not only myogenic patients were involved, but also some arthrogenic patients as well. And the effect was mean difference, which was above 3 millimeter. That can be considered as clinically significant, but unfortunately, mathematically, there was no significant difference. And as you can see, there is a little difference between these 2 data, and this can also questioning the usage of the additional splint therapy. As a summary, implication for practice is we should reconsider the usage of the splint therapy as the first non-invasive therapy in myogenic temporomandibular disorder. We need a multidisciplinary team, and also we should involve more physiotherapists in the field. The implication for research is we should need more investigations on the splint therapy, in which condition is the most efficient one. And also, we should do more investigations on pharmacotherapy as well. We should restrict the inclusion criteria, as psychosocial conditions can affect the outcomes. And also, we need some subgroups of the TMD classifications. And long-term follow-ups are also required. The strength of our work is that all the included studies were randomized control trials. The exclusion criteria is quite homogeneous, and all the included studies were using the diagnostic criteria of temporomandibular disorders. We also made an analysis on the 6 months follow-up, so a long-term follow-up is also included. And in all studies, we used the Michigan splint. The limitation of our studies, there were only 7 articles, so it's a few articles. Heterogeneity can be observed in the population, and some of the physiotherapy was conducted under different settings, and some exercises were done at home, which cannot be controlled, so the outcome was depending on the patient's motivation. As a conclusion, there was a small difference change between the intervention and the control group. So we can questioning the usage of the additional splint therapy in myogenic temporomandibular disorders. We should put a bigger emphasis on physiotherapy as well, but to distinguish our results, more randomized control trials should be implemented. As my secondary project, we would like to investigate the efficacy of different medical devices in the treatment of temporomandibular disorders, and we would like to make a subgroup analysis according to the Wilks stage. We would like to include the Wilks stage 2 and 5 as well. The 16% of the population has this kind of disorder, and arthrocentesis is an intermediate place between medical and surgical forms of the treatment. It can be conducted under local anesthesia as well, and we would like to compare the Ringer solution, hyaluronic acid, PRP, and also steroids as well to find a pain relieving method for arthrogenic temporomandibular disorder patients. Our aim was to investigate the efficacy of these medical devices. There was a network meta-analysis in 2020, but we have also added some other medical devices, which were the glucosamine and the chondroitin sulfate. And after all the selections, we could add 15 additional randomized control trials, so we can make a new network meta-analysis. Our question was, is there a difference in efficacy of different medical devices in the management of temporomandibular disorders? The P would be adults with temporomandibular disorders according to the Wilks stage 2 to 5. The intervention and the comparator would be medical devices, Ringer, hyaluronic acid, PRP, PRF, and steroids. And the primary outcome would be the range of motion that can be measured with the caliper in millimeter, and also the secondary would be the pain perception, the joint sounds, and the protrusive and the lateral intrusive movements as well. I have already done the data extraction, and we would like to submit it in September. Thank you for your kind attention. If the plan does not work, change the strategy, but never the goal.
Thank you. It was a wonderful presentation. I have an additional comment regarding your first project. You said that one study was a major contributor of statistical heterogeneity because of additionally prescribed painkillers. So maybe you could do a leave-one-out analysis and reduce to a moderate level to this heterogeneity, and that could increase your quality of evidence. And also, if you look at your first forest plot, based on the means and standard deviation, probably your data was skewed in 2 articles, and that's why you cannot reach statistical significance here. Did these articles reported mean and standard deviation like that, or you recalculated the data?
No, they were reported.
Okay.
In your first topic, did you find data on the time in the articles about patients wearing the splints? So how many hours did they wear it, and do you think it can be an affecting factor in the final results?
Yes, there were some information about how long they have to wear these splints, and it was about they have to wear it all day. They just have to take it out or remove when they were eating.
Will these results change the protocols of the treatments?
Hopefully, yes, but to distinguish these results, we need more randomized controlled trials in this field.
Thank you, Kata, for your presentation. It was very nice, as always. One question to your second topic. Do you consider to include IPRF as well? Because as far as I know, PRP is a little bit complicated to gain PRP, and the protocol is a little bit more complicated. And also in the articles, they usually nowadays starting to use the IPRFs.
Yes, we have already taken into consideration, and hopefully we can find any articles that we can add.
I also have a question. In your first topic, the diagnosis of TMD is not an easy stuff. So how about the homogeneity or heterogeneity of the diagnosis of TMD, and how the authors consider the cause or the final diagnosis is a myalgia?
Well, I have already contacted to all the authors, but unfortunately I could not really receive any replies. They were just texting us. They were using the DCTMD, but any further information or anamnesis was not added.
Because it could be kind of biased to how they figured out it's a myalgic type of the disorder. Thank you.